We also want to talk a lot about informed consent, and particularly around all the issues involved in memory. If we're talking about any kind of amnesia where the person may later remember something, you have to be very careful. There's volumes written about how to do this so that you don't get sued for malpractice, which has been a big deal kind of in my neck of the woods. And there are some real important things you should not do that we used to do routinely. They like suggest things to people based on a vague set of symptoms. Boy, you must have been traumatized. You have the profile of a trauma survivor. Yeah, we don't do that anymore. Intrusive hypnotic interventions to elicit memory. We don't do that anymore. It's against the standard of care. Some of us grew up that way, going after memory, trying to facilitate have reactions in a client who wasn't remembering things yet, because we thought that was the key to success. Let's abreact the trauma. We found that that's actually not true. Exposure and abreaction is important. You have to do it under certain circumstances. And some clients will never get beyond this to do that memory work. And that's really an unfortunate thing to have to acknowledge. And some clients cannot stabilize enough to do that more in-depth work. They're the ones where you can do 10 sessions of good work, stop, and then when they get symptomatic again, come back and do 10 more sessions. What are you doing? You're teaching them skills for stabilizing symptoms and for getting safe. And the kind of things that Marshall Lenahan teaches in dialectical behavior therapy. Wonderful, wonderful model for trauma survivors, for those of you who like it. Excellent skills. How many of you do DBT?
No, nobody in Singapore.
Nobody in Singapore.
Really? Nobody likes it or nobody doesn't?
I think there's only one lecturer in NUS that went for training, but it's still not established.
Well, you should do what the rest of us do. Just grab a book and read it, and then you'll be an expert. What DBT is, it's a modular treatment that you can do in a very limited context that teaches skills for managing, for affect regulation, safety, and interpersonal effectiveness in a context of mindfulness. It's wonderful. It's a wonderful model. Anyway, you're teaching skills for symptom stabilization. That may include focus on self-care. Many people who have chronic trauma histories do not take care of themselves well, right? There's this medical care, making sure the person's getting medically evaluated. I worked with a client for 3 months, almost exclusively on one issue, which was getting her to make a gynecological appointment that she hadn't done for 20 years, and was having significant gynecological symptoms that I'll spare you the details of. And I'm a psychologist and a male. This was great therapy. Can you imagine what those discussions were like? 3 months to get her to make the appointment. Why wouldn't she make the appointment?
You reminded her of the trauma?
Right, chronic avoidance, and reminded her of being traumatized. 3 months to just get her to make the appointment, which she then canceled. Repeatedly. So we went around and around many times with this. Eventually she went and had some issues, but they weren't anything life-threatening. So then she said, well, you see, I didn't have to go. Everything was fine. I'm sorry, you're right. So focus on safety. One of the things that we target early on is the suicidality and self-mutilation. The trauma-focused perspective suggests that you are not going to be able to get real better if you keep doing this. It has to be something that you work on if you want to get to a point that you can actually process trauma. And our rule of thumb is until this is done, we don't move into trauma processing. One of the ways you can significantly destabilize somebody is working on trauma before the self-care, self-functions, and stabilizations in place. Does that make sense? So going for trauma too quickly can destabilize people. Seeing it over and over, inpatient on a trauma unit, and that's how people came in. They went to work on a particular thing with a therapist, and they just weren't ready to do it. They were really symptomatic, it was premature, and they just fell apart. The system stabilization also, for a lot of people, involves pharmacological intervention. There's no one pharmacological agent that treats complex PTSD. There's not one that treats PTSD either, really, effectively across all 3 symptom clusters. Right? What do you prescribe for PTSD? I don't prescribe. What do you prescribe for PTSD? When you medicate it, what do you do?
Yeah.
And would SSRIs work best in terms of the 3 symptom clusters? Which ones do they impact the most? Sort of a trick question. There's 2 symptom clusters they tend to help. What's the one they don't?
Avoidance?
Numbing and avoidance. SSRIs tend not to make a dent in chronic avoidance. They're great for intrusive symptoms and great for some people for hyperarousal. But avoidance is something you got to work on behaviorally, psychotherapeutically. So again, symptom stabilization. We also we do a lot of work on training people in skills to manage symptoms. This is straight out of CBT, cognitive behavioral therapy, relaxation interventions, distraction interventions, imagery interventions to manage intrusive flashbacks. We'll do all kinds of interesting images. And then once the person has really developed some skills and self-capacity to tolerate distress, it's really all about affective tolerance. Once you've developed that over a period of time, so that the person can sit with their pain a little better, then you can begin to think about doing what's going to be sort of the next more painful phase, which is actually looking at what happened. Creating what some people have called the trauma narrative, putting your story into words in a more fundamental way. You've taken a history, you know something about what the client has been through, but in terms of processing it in an emotionally connected way, in the way that Edna Foa, when she talks about exposure therapy, talks about, you can't do that if somebody's wide open. Or they'll just, I guess if you want to get them hospitalized, you can do it. Then they'll be out of your office, but I don't recommend that. To do this work ethically, you really have to kind of renegotiate the informed consent before you move forward. So we're going to talk about the risks of doing this work. People will feel worse. They may behaviorally get worse. If their PTSD that was getting better, guess what might happen to that? It might get worse again when you start looking at this stuff. You got to tell people up front what the risks are. And the benefits. The middle phase is essentially the work on the trauma, so resolution, integration, exposure and deconditioning, and then all the work of grieving and mourning for what was lost. And usually that's not about the trauma per se, it's about the interpersonal context. So it's what have I lost? It's often about lost opportunity. Somebody who's been chronically avoidant, hasn't done things in their life that maybe they would have done if they hadn't been so frightened and traumatized. And there's a grieving that goes along with that, when you recognize that, oh boy, this has really impacted my life in a way that is not so cool. Then again, you only do this after you're sure the client wants to go there and you're sure they can go there without becoming suicidal or self-mutilating. The other thing we haven't talked about is substance abuse is extremely common, particularly when you start stressing people out by doing this. So you want to make sure if that's an issue, you don't move into this till that's really stabilized in whatever way you do that. And then later phase involves, a lot of people say late phase psychotherapy for trauma survivors is what we all go to psychotherapy for. It's just sort of the usual therapy issues of, I'm trying to live my life in a non-trauma focused way. So what do we go to therapy for? Relationships, we're not performing as well at work as we want to, we're grieving something, we want to develop ourselves in some way. Okay. Questions about just the structure that, again, no therapy looks like this, right? It's very personal to the client. But any questions about the phases or the idea that there's some work that has to precede others? Is that okay?
I think the notes you sent us, I think some of the notes were saying that it's obviously not a linear process, and you may have to talk a little bit about relationships to stabilize and back and forth. Does
that make sense? This looks good on a slide. It really does. Why is it outlined this way? Because there are going to be treatment guidelines that are going to be published. One that's already in existence is the International Society for the Study of Trauma and Dissociation has a guideline for treating dissociative identity disorder that mirrors the other guidelines going to be published in November by the International Society, Society for the Study of Traumatic Stress. They're actually 2 different organizations. The dissociative people split off. One their own order. Get it? Right. When we're talking about dissociative identity disorder in specific, a couple key issues we'll touch on. The phases of this